Hello everyone. Before we start today, I want to acknowledge with respect the Indigenous peoples and communities whose historical relationships with the land continue to this day and on whose traditional territory our work takes place. While we meet today on a virtual platform, we can take a moment to acknowledge the importance of these lands, which we each call home. So my name is Autumn Sipus. I am the project manager for the Canadian Coalition for Green Healthcare, and on behalf of the coalition and Peach Health Ontario, I would like to welcome you to today's Cut the Carbon Beyond the OR session, Green Healthcare Delivery, a Cardiovascular Care Priority. Throughout the event, please use the chat function for any technical issues you may be experiencing. Use the Q&A function for any questions you have regarding the presentation, and our panelists will be answering questions at the end of the event today. We'll also be recording this presentation, which will be sent to all of you or all registrants and will be available on our website and YouTube channel at a later time. I'm good. I also encourage you all to introduce yourself in the chat if you'd like. I'm sure our presenter would love to know who's here. So presenting today, we have Dr. Matthew Bennett. Dr. Bennett is a cardiac, oh my gosh, electrophysiologist.
Physiologist.
First time I've ever said that. After receiving his honors degree in mathematics at UVic, he went on to UBC for medical school, internal medicine, and cardiology, followed by a fellowship in cardiac electrophysiology at the University of Western Ontario. He has written 7 book chapters and 94 peer-reviewed papers. Pertinent to the topic today, he is the chair of both the Canadian Cardiovascular Society and the Vancouver Acute/Vancouver Community Medical Staff Planetary Health Committees, and has recently taken on the role of Planetary Health Lead for the Department of Medicine at the University of British Columbia. All right, take it away, Matt.
Perfect. Thank you very much. And thanks for inviting me to speak today. I'm honored to be here, and it's a little daunting to speak to the audience today. So I'd like to speak about green healthcare delivery really with a cardiovascular lens. So I'm a cardiologist, although it's amazing how narrow my scope is now that I'm primarily a heart rhythm specialist and don't see many general cardiology patients. So I've got some non-relevant research collaborations. I've drunk the Kool-Aid, as I'm sure many of you have, in terms of trying to make my life as green as possible. And I'm very much a believer, quote unquote, and try and do everything I can to reduce my impact on the environment. So some of the learning objectives today, the ugly, the bad, the good, instead of the good, the bad, the ugly. So talk about some of the effects of air pollution on the risk of mortality and cardiovascular disease, as well as cardiovascular events, including stroke, arrhythmias, heart failure, myocardial infarction or heart attack, and cardiovascular death. And then from a cardiovascular lens, what can we do to do ourselves or promote to improve the health of our patients by improving the health of the planet? I want to talk briefly. I've only just taken on this role as the planetary health lead for the Department of Medicine, and talk briefly about that strategy if we have time, and hopefully solicit some advice in terms of what your opinions are of how I should shape this role. It's an inaugural role, so there hasn't been a person in this position before, so I've got sort of a blank slate, so to speak. These are some of my collaborators and friends from the Canadian Cardiovascular Society. So my journey in this, I've been interested for many years, but really came to a head in 2020 around COVID, when I was interested in this and planning the Canadian Cardiovascular Society's annual conference. And I was asked to participate in our sort of kickoff session at the Canadian Cardiovascular Society's conference, and then lead the Planetary Health Committee there. And I'll shamelessly promote some of the work we've done throughout this. So this won't be news to the audience today, but in Canada, the healthcare system is responsible for 5% of greenhouse gas pollution, of which 25% of the adverse environmental footprint is from medications. And in BC, we think we're quite green, but we do have quite a lot of greenhouse gas emissions, primarily from transportation. But oil and gas is a big use or big factor there. A lot of the data, as you well know, is from epidemiologic studies, and I just highlight this for us to remember, and I feel silly saying this in this audience. This is sort of more pertinent for the non-believers and the people who don't think there's a link between planetary health and human health. But this is from the United States, of course, looking at the association between fine particulate matter concentrations. That's there on the left, with red being the worst, or dark black being the worst, and dark green being the best. Fortunately, I'm up here in Vancouver, which is just above here, but I'll show you that that's not much better necessarily. And then looking at the attributable mortality, with purple being the worst, red being second worst. And there's a clear association between these two graphs of the increases in fine particulate matter and attributable mortality. Cardiovascular mortality has also been shown to increase with air pollution. And this is from Europe, looking at the cardiovascular mortality in men aged 45 to 74. And of course, they could only get so specific because some of the mortality is not separated by specific region. But I think it paints a good picture that there is an association between the number of smog events and mortality in Europe. Some of my colleagues, embarrassingly, aren't believers and don't think there's a clear association, or think it's something from afar, where it's not really pertinent to us. We live in Vancouver. It's beautiful. We've got lots of trees, etc. But this is nitrogen dioxide concentrations from Vancouver. And so I'm speaking to you from here. This is Vancouver General Hospital, approximately. Fortunately, I live up here in one of these green dots. But you can see that the nitrogen dioxide concentrations clearly mirror the big highways that go through Vancouver and the Lower Mainland. And it's our grid structure, or our transportation structure, is such that many of my colleagues live, the hospital employees live out in Surrey, and will sit in traffic for a good hour, hour and a half on their way home. And so they're not only inhaling this at the time, but everyone who lives within this region is also being exposed to these nitrogen dioxide concentrations. So embarrassingly, I'll just draw your attention to the bottom left. Embarrassingly, I always assumed that air pollution resulted in pulmonary disease. And I'm terribly embarrassed to say this. And I thought the cardiovascular effects weren't as pertinent, or as relevant. But death attributed to air pollution is predominantly a cardiovascular problem, and people predominantly die of cardiovascular disease. Now, they have divided up the cause of death, and it's related to stroke, ischemic heart disease, so that would be myocardial infarction, heart attack, or hypertension. When we're in medical school, we learn, the risk factors for cardiovascular disease being high blood pressure, diabetes, smoking, and family history of premature vascular disease. But and that's being drilled into us, and this is one of my slides that where I try and convince cardiologists that this is a problem. But air pollution, this is the global attributable death risk, or risk attributed to different risk factors. And this is in females and this is in males. And air pollution is above diabetes in males, and is just below diabetes in females. And, it's not too far from hypertension in terms of that risk factor. So I think this is also one of the reasons why I think people should be discussing air pollution, where they live, how they get to work with patients to see if that's one of their risk factors for vascular disease. I have different, as I'm sure you do, different levers that I try and pull with different groups depending on who I'm speaking with. And again, I'm a newbie here, so I am embarrassed to say this audience, but there's a huge financial impact of air pollution to Canada, to the government. And so the Healthcare Canada estimates that air pollution was responsible for 15,000 premature deaths in 2021. And that accounted for $120 billion annually. Similarly, chronic exposure to fine particulate matter from burning fossil fuels is estimated to have 7,142 premature deaths per year in Canada, with a cost valued at $53 billion. That's from 2015. How does it, what's the pathophysiology? So one is in a polluted environment, and then the fine particulate matter will get into our bloodstream either through the nose or pulmonary alveoli or the GI tract or even cutaneous surfaces and mucous membranes. There'll be oxidative stress and inflammation and some neural reflex arcs, as well as things that I don't totally understand, like ligation of pattern recognition receptors, and that this will cause some biologic intermediates, autonomic dysfunction. You can read this as well as I can say it, so I'll keep going. And then it will cause endothelial dysfunction. So that's dysfunction in this inner layer of the blood vessels, which can result in plaque formation. There's also the risk of thrombosis, which is heart attacks occur because of thrombosis. Air pollution can result in hypertension, diabetes, and then plaque instability. So just in case it's not obvious, this part will be when somebody develops atherosclerosis in their artery, so cholesterol deposition within the artery. This will get bigger and bigger, but really the problem is when the top, this white layer, this is the endothelial layer, ruptures and then is exposed to the blood supply. And the way I describe it to patients is the blood sees this kind of as a cut and then scabs on it. And that clot, the scab, will block the artery. And then you end up not getting enough blood supply down to the right. And then that causes death of the heart muscle. So that's a heart attack. Over time, that can result in heart failure or heart weakening. But in addition, there can be a risk of stroke, similar mechanism, and arrhythmias. Okay. So I've talked about some of this already, but over the long term, there can be coronary artery disease, carotid artery disease, abdominal artery disease, thickening of the heart due to hypertension, and then chronic kidney disease. Many of these things are due to vascular disease. That's over the long term. And then in the short term, there's been association of increases in our common pollutants and myocardial infarction. So, I'm really lucky to be in this space because there's been a lot of support through the Canadian Cardiovascular Society and then at Vancouver General Hospital, which is part of Vancouver Coastal Health, both of which have planetary health as a priority. And the Canadian Journal of Cardiology proposed a special edition on air pollution, climate change, planetary health. And so I was lucky enough to be able to participate in that. This was one of the articles, and just showing you the table, I'll summarize it. So this article primarily looked at heart failure, so heart weakening, but also had examined just people without heart failure, some of which some of the studies here are from Ontario. So it is relevant to us, some from Montreal. but there's an increase in incident heart failure, myocardial infarction, stroke, and mortality with air pollution exposure. Similarly, increased risk of heart failure admissions and readmissions with air pollution exposure, and heart failure mortality. I was able to collaborate with some of my colleagues looking at arrhythmias, so I'm primarily an arrhythmia physician, which is probably how I should introduce myself, Autumn, instead of cardiac electrophysiologist. But so there's an association. So we implant pacemakers and defibrillators, and that's what CIED is, a cardiac implantable electronic device. And the nice thing about these devices is they watch, they're able to document arrhythmias, whether from the atria or from the ventricles, and at what time they occur. So this is perfect for studies where we can look at air pollution changes and the effect down the road on the risk of arrhythmias. So there have been increased risk of atrial fibrillation. So AF is atrial fibrillation in patients with ICDs. Similarly, an increase in the risk of ventricular arrhythmias with pollutant levels. Increase in hospital admissions and ER visits for AFib, and that association with the increase in pollutant levels. Interestingly, in patients, so we used to use Coumadin for atrial fibrillation to prevent strokes. So Coumadin is a blood thinner, and it's also a vitamin K antagonist. That's its mechanism of action. And what they found was there was an increase in both stroke, bleeding, and mortality in patients on Coumadin, and that was associated with pollutant levels. We've talked already about mortality, but there is an increased risk of mortality with increases in pollutant levels in patients with atrial fibrillation. So that's a Montreal study. And an increase in out-of-hospital cardiac arrest. So OHCA is out-of-hospital cardiac arrest with pollutant levels. So this is a really, pertinent problem for the cardiovascular patient. Similarly, over time, there's an increased risk of atrial fibrillation with chronic exposure to increases in pollutant levels, and an increase in the risk of sudden death with chronic pollutant levels. So acute and chronic increases in pollutant levels cause increases in arrhythmias. So I try and, I always feel so like this weight has come down over the audience when I say all this, and find it so depressing. And Miles knows I'm an avid cyclist, so it may be stormy, but we can still win. So there's my family yelling, which is awesome. Lots of fun. Kudos to them for coming out in this miserable weather and being happy to see me. Okay, next. Okay. So sorry for that. And I always have to remind myself to not talk about biking because I could spend hours and then all of a sudden the time would be over. I'm sure you've all seen this, but this is kind of one of my slides to give people hope. And because that's often one of the problems, right? Is people will say, well, what can I do? It's the damage is done. Why should I do anything? And so I try and keep it optimistic. So this is looking at the United States again from 211 counties in 51 metropolitan areas all across the United States. So these were the cities that were included. And this is looking at life expectancy within this time frame from 1997 to 2001, and the fine particulate matter concentrations from 1999 to 2000. Now, the solid line is at a county level, and then in the broken line is really looking at it from the bigger metropolitan area of which some of the counties are exposed or are within. And there was a clear association, and granted, this is an association, between the concentration of PM 2.5 and life expectancy, with, of course, higher PM2.5 levels and lower life expectancy. So that's not necessarily optimistic, but the cool thing was, next, is when they put this into a model and looked at differences in the change in the PM 2.5 over time. And good news was is it did reduce over time. So I'll orient you here. This is reduction in PM 2.5. So there's the compared to the initial values, this is more reduced. So lower, it had lowered more if you're over on the right side, and hadn't lowered at all if you're at zero. And then this is change in life expectancy with no change versus a substantial reduction in mortality or life expectancy. Now, overall, and this was put into a model, and despite correcting for multiple variables, this still bore out. But life expectancy improved in everyone, regardless of the PM 2.5 effect. So if your PM 2.5 didn't change, you still lived longer as time went on due to multiple factors that I'm sure we can all imagine. But there was an improvement in life expectancy if the PM 2.5 reduced more, if that makes sense. So these are some shameless plugs of some of the work we've done through the CCS. And this, what can we do for our patients? So the big thing is to plan in advance. Well, one of the factors is to plan in advance. So in Vancouver, we've really been exposed to floods. I took out my flood slide, and wildfires. And that changes a lot of factors. So fortunately, I live in the hills, and I've got AC in my house, and I can turn the fan on and get a great filter, etc. But and I'm not exposed to floods. But not all my patients are in the same situation. So we should create a plan with them in advance of when these either wildfires, extreme heat events, or floods will occur. And so, for example, where will you get your care? So, who will you see if you have to be displaced from your home? Do you have enough medications that you can still be able to take your medications if you have to leave in a hurry? Do you have a go bag? I love the term go bag because it makes me feel like a spy, but do you have, toiletries and clothes and all your medications, and what's your action plan if you need to locate somewhere else? This was an air quality advisory tool that we created. So you can put in your area code or get your location, and then put in which group you belong to, and then it will find out what the air quality index is in your location, or the heat level in your location, and then we'll give you specific recommendations depending on that. So for example, that maybe there's no restriction, or don't exercise outdoors, stay indoors with filters if you've got them, or stay somewhere else. If it's high heat, you of course will observe for symptoms. So people need to know what those symptoms could be, and this includes that. You might cool at home, so stay in a cool room, have a cool bath, stay in the bathroom where the bath is cool, and that will cool the room. Go to cooling locations, or stay somewhere else that where you can get cool. Similarly, in our neighborhoods, we should get in the habit of checking in on our vulnerable populations to check in and see how they're doing. So I try and be sly. I say that out loud, but it's not that sly actually. And this is for the cardiologists who don't necessarily believe. This is a recommendation from the dyslipidemia guidelines, so the cholesterol guidelines, and has nothing to do with planetary health. And so I promote things that are, people believe in, just in case they don't believe in planetary health. Which surprisingly people don't still. But the Canadian Cardiovascular Society recommends that adults should accumulate at least 150 minutes of moderate to vigorous aerobic exercise or activity per week. And that has been in the guidelines since 2021. And so I suggest that we do that in the form of active transport. Shout out to we have had a podcast series, and we spoke to one of our exercise specialists about this, and that's on the Cardio Connector website. I love this, and I'm sure you've all seen it, but the Park RX, that you can sign up to be a prescriber, and then you can prescribe getting out in nature. And with that prescription, you can, the person you've prescribed it to will get free admission to different places, or reduced admission to different places. Like, for example, Van Dusen Gardens, which is a big park, private park in Vancouver, lots of beautiful trees, etc. They'll get admission to that if we prescribe it for them. But I think just putting that emphasis on it to our patients is important, because if we say it, people realize it's important, and we carry a lot of weight with what we recommend. Just on the subject of food, which I'll come to, this is looking at blood vessels from I think I'm not actually now I don't remember. No, it was an animal model. Animals exposed to filtered air and a normal diet. So this red is the vascular disease or cholesterol plaques, you can think of it. This is exposed to polluted air, so predominantly PM 2.5. This is filtered air, but a fatty diet. And then this is the double whammy of fatty diet and polluted air. And so I don't think it's hard to see that there's not only fatty diet and polluted air have a similar level of vascular disease, but the two together are potentiated. And again, this is my sly way of recommending that cardiologists change their recommendations or support the recommendations that the Canadian Cardiovascular Society has suggested to decrease the amount of meat in a patient's diet. And this is directly cut out of the guidelines. So we recommend a Mediterranean diet, which has evidence of cardiovascular outcome benefit. This is what the Mediterranean diet is. In addition, other diets such as the portfolio diet, the DASH diet, and low glycemic index, glycemic load dietary pattern, plant-based dietary pattern, as well as dietary patterns high in nuts, legumes, olive oil, fruits, vegetables, total fiber, and whole grains. And so, in essence, decreasing red meat. This is a cool document that one of my colleagues from the CCS, she's on our committee, she's a dietitian, and she created this for the Toronto Public Health Group, Diets for a Cool Planet. And some of these slides are from her document. And so this looks at the carbon footprint of each of the different food types of food. So vegetables, field grown as the lowest carbon footprint, and then you can see it increases. And as you get into sort of the animal-based proteins, it goes up with beef and lamb being the highest impact. The good news is that the low carbon footprint foods often are the cheapest. So there's this, again, co-benefit of eating a plant-based diet and cost. So again, sort of ammunition to support these recommendations to patients. So it improves cardiovascular health and is cheaper and has a low carbon cost. So as part of my role, I'm the chair of our Medical Staff Association's Planetary Health Committee. And here we've interviewed some physicians who follow a vegan diet. Margaret Davis is one of those physicians. She's a cardiologist, which is why I'm highlighting her. She's a specialist in heart failure. And just to highlight that some of our colleagues do follow a vegan diet. I must say I've been vegan since the end of 2019. And before that, I actually I wasn't a believer, and I didn't think it was important. And I've stayed a vegan since. And I think just exposing people to other people's stories that and kind of normalizing it, and then also really acknowledging some of the difficulty in following a plant-based diet and some of the barriers that people come up against and how they resolve those. I think this was an important piece as part of our VPSA. The VPSA is our Medical Staff Association. So I think it was about 12 interviews. We interviewed with some of the physicians who are vegan and really highlighted in their region, we had a psychiatrist, an internal medicine specialist, anesthesiologist, why it's important for them and their patients and them personally, and then some of the barriers. So again, shameless picture of biking. So I do this bike race every year called the Whistler Fondo, and so that at the end of the race, there's a combination. This is so some of these guys are in the Whistler Fondo, and then I was just because I'm a glutton for punishment, I did this race called the Forte, which is where you go up Cypress Mountain first and then do the Fondo. And you start an hour early, etc. I won't talk about it. I warned you that I could talk about it for hours. Um, and this is, after 4.5 hours, this is the guy who won that race, and then this is me in the background. And the my point here is, that you don't have to win in doing some of these recommendations. You just do something. It can be a little thing. You don't have to boil the ocean. Just do something small, and this won't come as news to the group here, but some of my colleagues will get paralyzed with thinking, oh, well, I'm only one person. What can I do? My impact won't make a difference. And I try and really espouse that do one thing and the ball will start to roll, and you'll be surprised at how big the snowball gets. But after you've done just one thing to start. So I was, really felt fortunate to be able to collaborate with Miles in the group, um, and created this toolkit. So it's a sustainability and cardiovascular care toolkit, and I feel like a little bit of an imposter because Ilya and Miles did all the work, and well, I guess we all work together, but I'm appreciative of the collaboration. So I'll go through these, and I often hate reading from slides, and so I'll try and collate these or combine these together where pertinent. But um, really, it gets down to reduce, reuse, recycle. So many of our patients have life-threatening conditions, and figuring out what their prognosis is, what their preferences are, and the goals of their care, so that we're not doing tests that they don't want. We're not doing tests that they don't need and won't change their mortality or morbidity. And then around the goals of care, we're not, bringing them to the hospital and putting them in the intensive care unit if they wouldn't want that anyway. So really making sure that that's obvious to them, or not obvious to them, that's obvious to the physicians and their families, so that if they do end up having a cardiac arrest, for example, everyone knows what the plan is. Um, there are some, things that many, for building recommendations such as energy efficient LED light bulbs, um, turning off computer monitors, etc. Um, we've started to create a green leaders group, as I'm sure many of you have in your hospitals. But having someone who's the green leader in that area who can really oversee an implementation or implement sustainability initiatives and provide guidance. And I'll come to this a little bit later, but within the hospital, we've got a green team, and I'll highlight what that looks like. Try and minimize the printing of reports and results. So thankfully, we've gone paperless in many of the areas in the hospital. The stress test would be quite a thick amount of paper for every patient. And so we've minimized the need for manufacturing the paper and then the recycling of that afterwards. Avoid non-sterile gloves when hand hygiene is sufficient. Gloves aren't magic. We, often just our skin barriers are much better. Like our skin as a barrier is much better at keeping germs out. Um, then implement relevant teaching on sustainable healthcare in cardiology curricula. And I'll go through what we've done as part of the CCS. Don't dispose of medications in sinks or drains and garbage bins, but dispose of them well. And then try and communicate by Zoom or another video communication technology in place of in-person conferences or meetings, whether that's with conferences, meetings, or with patients. Sometimes it's not possible, but it should be considered. We should support the use of or the recommendation of plant-based food options. One of the general surgery residents who works with Andrea McDeal, who's a planetary health guru here in Vancouver, has taken on this project in the hospital where she has looked at what the uptake is of patients in the hospital, like inpatients, and how much waste there is, and has shown that there's a huge improvement in the carbon footprint, and that there are certain meals which are they're eaten more fully than others. And the good thing about these meals is they're all more nutritious than the alternative. We should try and have the option for people to bike to work, so safe bike racks, uh, lockers, showers, to facilitate that. Every year I try and get one or two of my colleagues at least to try and bike where they hadn't biked previously, and ask them, okay, where do you live and where let me give you a route that's safe, because that's often what people worry about, is getting hit by a car. EV charging stations at the hospital, uh, use reusable gowns instead of disposable gowns, switch from IV to oral medications, um, try to discharge patients on the same medications that they were taking at the beginning, when they were admitted to hospital, rather than switching to a similar, from ramipril to enalapril. Those are both ACE inhibitors, when ramipril is as good as enalapril. Um, Only use the tests that are appropriate, that make sense, and that will make a difference. Avoid performing a stress test, stretch cardiac imaging, excuse me, or advanced non-invasive imaging as preoperative assessment in patients who to undergo low-risk non-cardiac surgery. So again, most of these are um, appropriate use criteria, and I'll come to that in a second. Don't do tests that won't make a difference, so avoid routine daily blood tests. I'm seeing the time, and I do want to leave lots of time for questions, um, but I'll go through these as I can. So offer home-based cardiac rehab. Um, and that's the Cochrane's reviewed this, and it's as effective as in-person cardiac rehab. Consider virtual visits for patients instead of in-person, where the equivalent clinical value is offered. Um, Recommend daily exercise, plant-rich diet, and prescribing nature. Recycle or don't use the paper on exam tables. Um, and promote deprescribing practices. And again, don't do tests that are unnecessary. Um, There are a few cardiac surgery recommendations, some of which are covered in the other, what I've said already, but avoid the insufflation of the surgical field with CO2, as it doesn't improve things. And then this has always driven me crazy. I put in pacemakers, and the tray comes with about 50 instruments, of which I use five. And so we've really cut down on those so we don't have to clean as many instruments. Um, a lot of these here are the cardiac cath lab. So this is where I work. It's, technically it's the EP lab, but we do the procedure rooms. A lot of it is, again, minimizing your waste, but also only doing tests that are appropriate. And we're lucky enough that the American College of Cardiology has come up with appropriate use criteria where they have said, okay, you should only be doing these tests for these reasons. And those are really well listed in these documents. The nice thing as well is it's um, cheaper for the healthcare system if we're only doing tests that are appropriate, which makes sense. Something that I haven't discussed is ensuring good quality care, which everyone wants to deliver excellent quality care, but good quality care will also minimize readmissions, mortality. It'll be the right dose, the right drug, and right dose for the right patient, etc. So that's another lever I try and pull with the administration is let's see if we can improve our quality of care. I wonder if I'll keep going, but I shall wind down shortly. So I talked about the green team idea. So with in cardiac, we had some interested people. Richard Cook's one of the cardiac surgeons. This is me. We had the support of our administrator, and then we had some of the nurses who were really keen on planetary health, some of which had been funded by a team-based quality initiative funding, and we were able to get the staff, the staff that are employed by the hospital, to have some time set aside where they would be free from their usual duties but still paid to work on planetary health initiatives. And this has really worked well for us because they're paid to do it, so there's a bit of responsibility placed on them. They have time set aside, so that they'll actually do it. And doctors, I think we're kind of useless because we're busy, and often can't sort of put time aside to do some of the initiatives. But this has worked really well for us. So our next plan in this development is to have green teams throughout the hospital. Um, this is our group for the doctors and nurse practitioners. This is the Medical Staff Association group. And we had recently a Green Enthusiast Network launch where some of those members, so it's funded through the Doctors of BC, which means that it has to be the doctors and nurse practitioners, but where we all got together and we shared ideas, and then on a regular basis, we will be telling each other about our projects and our barriers and see if we can help one another. And then each of these groups will also have a green team. I'll briefly just skip over this, but this is what we've proposed as our curriculum, or really the objectives for a planetary health curriculum for cardiovascular trainees. My group is terrible for flying too much for research meetings. So this was one of my buddies who I said, "Hey, are you around to do a pacemaker next Tuesday?" And he said, "No, I'm flying to Toronto. I'm going there tonight." This was on the Friday, coming back and then going out again on Tuesday. I said, "It sounds terrible," but really just to say, like, we need to fly less, and virtual meetings are great, and I do acknowledge that there's a certain amount of networking and water cooler talk, which is so important. Like, for example, for the Canadian Cardiovascular Society meeting, I've been trying to figure out how to make this more into a virtual meeting, whether we have a few different hub meetings where all of the BC people come to Vancouver or Kelowna or what have you, and then some of the speakers fly to get that interaction. But I haven't really cracked that nut in terms of how we still get that impromptu hanging out and talking and socializing part that's so important in networking. Um, Briefly, in the last couple of minutes, so I, I'm new to this role. It's only just started earlier this month. So I'm sort of haven't been given my marching orders, so to speak, in terms of this strat plan and how this will incorporate into that. But my ideas have been first to, I've been identifying local experts who have an interest in planetary health, who are from the Department of Medicine, so respirology, cardiology, etc. And then in each of those areas, really create a curriculum of objectives and then build a lecture series where we'll talk about the effect of planetary health on human health, how it pertains to their discipline, so gastroenterology, respirology, etc. And then hopefully, if the checklists haven't been created, then create those, hopefully with Miles and the team, and then promote the work. First going to internal medicine, then other divisions, and then within the other divisions, really planetary health allies, and then divisions without allies, and hopefully that ball starts rolling. And then it will be first with the trainees and incorporating into the training curriculum, and then into sort of the clinical staff. So that's sort of the plan for that. But would really love either now or later to have people's advice there. If you've done this before, please contact me. So, in conclusion, climate change has substantial cardiovascular effects. I think it is a healthcare issue. I always say that I think cardiologists should be the main proponents of improvements in planetary health because it affects us the most. But that's really my petition for the cardiologists. I think it's important for everyone. Extreme weather events keep occurring, and we need to prepare our patients. And then doing one thing will make a difference. So keep doing things as I'm sure you are, and I'm a little embarrassed to say all this in front of this awesome crowd. But so with that, I thank you for your attention. It's always difficult to speak to myself and and not hear the background laughing at my jokes, which I'm sure you all were doing. Um, so happy to entertain any questions.
Hey, Matt.
Good
Great
morning.
job, Matt. Love that.
Thank you.
Love that you did impacts on human health, resiliency, adaptation, and the mitigation piece. We didn't even ask for that, but you hit all three.
Okay, good.
Yeah. And I didn't see any questions in the chat, Autumn. Did you see anything?
Think there's one here. Lots of
Okay.
dialogue
Okay. Yeah. Go ahead. Go
around
ahead. Yeah. Yeah.
diet and eating and all that. And we had one kind of pondering question from Tanya about how, our food has obviously tends to have lots of pesticides and fertilizers, and wondering about that impact of that on heart health.
Yeah, I haven't looked at that much, to be honest, and this is where I get out of my depth pretty quickly because I am primarily a heart rhythm doctor, and and when I see someone who has got general cardiology problems, I usually refer them on to colleagues. But uh, I think that there definitely are effects of some of the different pesticides on the heart. And I think trying to, oh yeah, good. Thanks, David, I see you've got something in the chat bailing me out. I appreciate that. Um, yeah, some of the different pesticides, and they're not on the heart. And I'm thinking about that one slide that I showed about the change in the blood vessel over time, and that New England Journal article is amazing. Looking at planetary health and the effects on the cardiovascular condition. Um, so I think it's important to trying to avoid pesticides, of course, but that isn't my area of expertise, so I shouldn't really talk any longer about it.
So, Matt, you did talk a bit about this, your new role, which obviously an academic role. And do you want to talk a little bit more? And this is in part for my sake. Obviously, I do some of this work at McMaster. I'm interested in what you folks are up to and where you're heading, because I know BC is definitely ahead of Ontario in this sector.
Yeah, so the university, the Faculty of Medicine, and then the Department of Medicine, of course, is within the Faculty of Medicine is predominantly the ologies, respirology, nephrology, etc. They've all got planetary health points within um, their strategic plan, and there are different I haven't actually seen the granular strategic plan. It's really the general for public consumption strategic plan, to try and minimize our effect of the hospital and the way we treat patients and how on the planet, to try and everything, the climate resiliency, and create the link. And when I interviewed for the position, the slide that I showed is what I've proposed. So it's a huge area and with a lot of depth, and this term is 5 years with I can renew it once, and so there's a lot of work to be done over a long time. But the initial plan would be, to target the trainees and their education series first, with creating objectives and then a curriculum. Then next step is get it in the academic half days, for example, with lectures divided up into, the general, what's the association between human health and planetary health? How does it affect the gastroenterologist, for example? And what should the gastroenterologist be doing in their area in their work that will improve the planet? And then from there, ideally go on to create some teaching modules. Everybody learns differently, and I've had these conversations with people who say, well, we've already done that as a podcast. Okay, well, but podcast and a webinar is different. Some people will attend one and not the other. Some people are readers, and so let's do both. And so create modules, sort of CME modules on each of those, and then try and get them from the trainees to the staff, who maybe, trainees are often more keen, because I just find that the younger people are more interested in this than some of the dead wood. But and then get it into the staff group. So it'll be predominantly an education
Yeah.
portfolio, so to speak.
We could talk more offline. Really, really
Yeah, great.
interested in some of your thoughts there. And I can tell you from my perspective, it's been a lot more easy to get engagement from the medical students and the residents, just because maybe the residents are too busy. I think there was a question in there that I missed, Autumn, about food. I think it was. Let's see here. Do you see it? Um, ba- ba-
I don't see anything about food, but I see
okay, here's.
David was just following up.
But then there's one from Alex. I just want to know the link between air pollution and type 2 diabetes. Matthew, do you have something for that?
I don't have a specific answer for you, but I
Right.
can get it. Yeah,
Okay.
yeah. Sorry. It is.
No.
We know that increase in inflammatory markers increase sugars. So I presume it's due to that, but um,
Right.
Alex,
And another one. Have you looked at Vancouver's projected cost savings and indicated this to your MPPs?
yeah.
That sounds like a Cape thing, maybe, but go ahead. Yeah.
Yeah, it's a great question, and no is the answer. We're quite early on in this. Um, the so some people have done this work, and I think that's why these interactions are so important. Is um, there's no point in me repeating what's been done in other areas, and So yeah, I'd be interested to hear if anybody's done that in their regions, and I think it would be great, and I think maybe there are these metrics in other areas, but just to show what the cost savings are if we do X, Y, and Z. I know Miles, you and I have talked about the carbon effects of different medication, eliminating medications, and it's nice to have those specific numbers for patients and physicians. David, I agree. I think that needs to be promoted to whoever the important people are, in terms of figuring out, okay, if you do this, this is the effect on the cost. Um, but-
Like for this application gateway or all of the different configuration settings.
Last one here, and I think we're almost out of time. Do you have provisions for introducing carbon capture solutions in the hospital environment, including OR rooms? And I think that might be beyond your scope. Maybe the facilities folks are looking at that, but go ahead, Matthew.
Yeah, it is. It is sort of beyond my scope. As I'm sure has been obvious throughout this, I get excited by a lot of these things, and I really have to put the reins on and really try and stay as much as I can within my area. And so yeah, I haven't looked at that, and there are people from the hospital, like planetary health interested people who have been speaking to facilities. I'm lucky that at Vancouver Coastal Health, so that's our big health authority, of which Vancouver General Hospital is one of the hospitals. Um, one of their pillars is planetary health. So we have, the labeling, and now it's time for us to sort of put the rubber to the road and hold people's feet to the fire, so to speak. All those great cliches.
Yeah, amazing. Well, look, Matthew, thank you so much. Love that talk. And thank you, Autumn, for organizing things as usual. And thank you, Autumn, for all the guidebooks you're putting out there, because you're part of that too. So thanks everyone for coming today, and have a great weekend.
Yeah, thanks for inviting me, and thanks very much for your attention.
Yep.
You too. Thanks, everybody. Thanks, Matt. Take care.